Good afternoon, everyone. I'm Dr. Ibrahim Al-Obaida. Today, I'm going to present primary open-angle glaucoma. It's a huge topic, so I will try my best to explain or to talk about the most important point in the primary open-angle glaucoma in my point of view. Lecture will be outlined by this element or this category. We'll start with the definition, then we'll go for epidemiology, then we'll talk about risk factor and pathogenesis, and then we'll talk about clinical assessment, especially optic nerve disc assessment. Then we'll finish up by talking about how to manage patients with a primary open-angle glaucoma. So to start with, it is very important that you label or you diagnose your patient in a proper diagnosis or the correct diagnosis, so your management will be correct. To diagnose a patient with a primary open-angle glaucoma, it is very important to know the definition of the primary open-angle glaucoma, which is a chronic progressive optic neuropathy in adult, characterized by all of the following. So you should have all of the following to be able to label the patient with the primary open-angle glaucoma. First of all, it's to have an evidence of glaucomatous optic nerve damage, either by the appearance, by looking to the disc and seeing a cupping, or by imaging, by doing a nerve fiber layer image, or by doing an investigation like a visual field to see characteristic abnormality or changes in the visual field. Also, it's very important to do gonioscopy examination and to make sure that the angle is opened and normally appeared angle, and to check if there are no other causes of this open-angle glaucoma or increase in intraocular pressure, like a steroid-induced glaucoma or other inflammatory cause of glaucoma. Then after that, to have a primary open-angle glaucoma, patient should be an adult and should be more than 40 years old. Otherwise, if it is less than 40 years old, this patient you may label him as a juvenile open-angle glaucoma. Then about epidemiology, it is very important also to know that what is the distribution of primary open-angle glaucoma and how common is the primary open-angle glaucoma. The prevalence of primary open-angle glaucoma for adults aged more than 40 is around 3.05 in 2013. This prevalence by studies suggested that it will increase around 50% worldwide, from 52.7 million in 2020 to 97.8 million in 2014, which give us a hint that also this is the type of glaucoma is commonly and it is increasing with the time. And it's also very important to know, to keep in mind that by study proving that primary open-angle glaucoma is predominant type of glaucoma in Western region, whereas the highest incidence rate is among people from African descent. While in our region or in our area, it is lower than what is in Western region. This brought us to a good question. What about our region? What about Saudi Arabia for primary open-angle glaucoma? Unfortunately, we don't have a population-based study or epidemiological studies that give us a good prevalence estimation for primary open-angle glaucoma patient. Some studies done, and Prof. Salih Al-Obaidan and his group did a nice study that they studied their patient, and they found that primary open-angle glaucoma contribute around 12.8% of all type of glaucoma. Other hospital-based study by Dr. Tariq and his group found that the prevalence is around 38.1. And they contribute the higher number of their primary open-angle glaucoma patients because of their inclusion criteria were more open, and they include Saudi and non-Saudis patients, and also they include different type of patient. That's why they're more have a higher risk, a higher prevalence of primary open-angle glaucoma. And as you can see the difference between two numbers, you can know that there is a lack, or there is uncertainty of how many patients, or how is the prevalence of primary open-angle glaucoma in our region. Then we'll talk about the risk factor. I will go briefly about talking about the first 5 elements of the risk factor, which is the most common or the most important risk factor for a patient with a primary open-angle glaucoma. Now we'll talk about intraocular pressure. Is 21 millimeter mercury is a magic number? Are we putting a cutoff number that's suitable for all of our patients? Because usually what we face as a glaucoma specialist or non-glaucoma specialist, that when we see the patient with less than 21, we're more relieved or feel that this patient is not a glaucoma patient, and we reassure ourselves that the IUB is low, so it's unlikely to be glaucoma. While in the studies, population-based studies suggested that half, which is a 50% of all individuals with the primary open-angle glaucoma, they have the IUB level below 22 at the beginning of the first seeing visit. So as from this information that we know, the 21 or 21 IUB is not the good element to rely on only in screening or looking for the patient. But also don't forget that other studies demonstrate that the IUB relation or increasing also associated with higher prevalence of primary open-angle glaucoma patients. And about the relationship between the IUB and open-angle glaucoma or glaucoma in general, you should keep in mind that there is no fixed number can be generalized to all the patients. You should always correlate or put individual target or variation for your patient. Some patients, they can tolerate a higher number, and some they're not. So as only number, we're not treating a numbers, we're treating the patient with a progression either or with a glaucoma diagnosis in the beginning with. What about the age? As we all know that the age is a risk factor for developing primary open-angle glaucoma, and many studies done for that, for looking for that risk factor. And what I want you to look at is that if you see here the 70 years old and above, when the patient reached to that age, almost all the prevalence almost doubled. So when you have a patient less than 70, their percentage of getting primary open-angle glaucoma is doubled with reaching 70 years old, which is a very important point to keep in mind for screening the patient or for looking for primary open-angle glaucoma patient. And increasing in the age also increasing the risk of getting primary open-angle glaucoma. The more age you have, the more risk is to have a primary open-angle glaucoma. What about family history? We all know that the family history is a part or the risk, part of risk factor of a glaucoma, primary open-angle glaucoma. As you see here, the primary open-angle glaucoma is increased by 9.2% twofold higher in an individual with first degree relative with a glaucoma. Not only that, the number of siblings that affected by glaucoma is a very important question or a very important history because this might increase the patient risk even to five-fold higher if there were two or more siblings with a glaucoma. So it is not only asking about family if he or she had a positive family history. It's also asking how many members affected and what is the relation of that member to the patient. Corneal thickness. One of the risk factors is to have a thin cornea, and also corneal thickness play major role in IOP measurement. As we all know that the average corneal thickness is around 552 micron, and there is no standard nomogram that correlate or correct the IOP in regard of the corneal thickness. And as we mentioned, the cornea is play two major roles for glaucoma patient. The first one is changing or playing a role for IOP measurement, either by underestimate with the thin cornea or overestimate with the thick cornea. And also the thin cornea is per se a risk factor to have a primary open angle glaucoma patient also. As we see with, as you can see with the diagram, that when they categorize the patient to three groups, which have a thin or normal or thick cornea, the thinner cornea is the higher prevalence of open angle glaucoma they have. So thin cornea per se is a risk factor to have a primary open angle glaucoma, and also it's play major role in IOP measurement for that patient. What about pathogenesis, or what is the pathology behind the glaucoma or primary open glaucoma, especially in this dog? There is a many theory or many mechanism have been published about developing a glaucoma. One of it is cellular stress, or what we call mechanical changes or damage, which happen with a direct effect of the intraocular pressure on the ganglion cells. And this effect will reduce the retrograde exoplasmic flow. And this stress on retinal ganglion cells and cause their death. And also there is an effect of high pressure, or the pressure directly in the glial cells in the optic nerve head, microglial and also astrocytes. And this will activate those cells and will make, with increased intraocular pressure, and this will make more biomechanical effect on the optic nerve head and tend to increase the stress on ganglion cell layer. Other mechanism is the structural change, which with this mechanism of this theory, they proven that there is a change in the pre-laminar or posterior deformity of laminar cribosa here. It's begin with this area, and then after that, with this changes, this will eventually make more stress in the axial axons of the ganglion cells, and will make more strain and retinal ganglion cells axon, which will compromise further the function of axon itself. And this will cause by bowing or cupping of the area in the laminar cribosa, and will make stress in the axon of the ganglion cells. Other theory or other mechanism, they proposed that the patient shows indirect evidence of inflammatory process. as indicated by presence of auto antibodies against retinal antigens. And this will activate what we call programmed apoptosis, activated by MHC class 2. And this process will further contribute in degeneration of the ganglion cells by programmed apoptosis or programmed cell death. So there is some sort of inflammatory, or what we call an auto antibodies against the ganglion cells, which will cause their death by apoptosis. In conclusion, glaucoma is a spectrum of disease. It's not a one stage or one step disease that happen once. It's more of cascade that happen by sequence of actions to the retinal ganglion cells, especially. And before patient present to you or have any symptoms or nerve fiber layer damage, there were a sequence of damage that already happened to the patient. And what you see, or when the patient is coming to present to you, he already passed all that area and have what we call a damage that can be detected by examination or by visual field test. And this gives us a hint that if we were able to know more about the early beginning of glaucoma damage or glaucoma changes, we could prevent, or we could start from early on of the glaucoma stages, which will cure and will have less nerve fiber layer loss before we get to the end stage visual field damage. And as we all know that we only have one risk factor that we can change or we can modify, which is the intraocular pressure. And this is the only risk we can modify, and this is the risk we can change it, or we can do something for it. Unfortunately, till now, we don't have other than that to control our patient, or we try to prevent further damage to the nerve fiber layer. Now we'll go to clinical assessment. It is very important to have a comprehensive initial glaucoma evaluation for any patient that present to you as a glaucoma suspect or primary open glaucoma. And a message I want to deliver also that sometimes you will not be able to diagnose a patient in the first beginning or first visit. Sometimes you need a sequel of investigation, sequel of evaluation, so you confirm your diagnosis. So don't be rushed to label the patient if you're not sure about the type of glaucoma, or you're not sure if the patient had a glaucoma or not. From the clinical assessment, the most crucial part of assessment patient with a glaucoma is the optic disc. And we are only using one system or one staging system, which is might not be the optimum for our patient, or might miss some of progression or some changes that would not able to detect by only taking optic disc damage. We'll see here that there is, you can see here that there is many different staging systems were published previously, and we'll go through some of it quickly. The one we're using now, which is the AMREL's methodology, which is grading the cup to disc ratio, as reference to this picture. As you see here, it starts from no cupping till you reach what we call 0.8 to 0.9 of total cups. And this rely on the disc to cup ratio, and you generalize it to the stages, or you can know the stages in regard to the cup to disc ratio. I will give one example that give us what defect or what we're lacking in this system. As you can see here, this is a disc photo showing what you will say that it is 0.3 cup to disc ratio. With Amral's methodology, what we can mention that it's only patient with a 0.3 cup to disc ratio and has an inferior notch, and we might mislead by the 0.3, and we thought it is a mild or no glaucoma even patient if you're just looking quickly to the disc. So as you saw previously, that 0.3 cup to disc ratio differ if it is centrally or it is eccentric. So the more important is the rim of the cup to disc ratio rather than the size of cup to disc ratio. So if you have a 0.3 centered disc, it is a good sign, but if you have it eccentric, that means there is a loss of nerve fiber layer in that area. And 0.3, it is not a mild or no glaucoma patient. From that, we can conclude that even a patient with a 0.8, what we think it's an advance, they might have a normal cup to disc rim and normal visual field and normal without glaucoma. But even with a 0.4, it might have a glaucoma and also might be an advanced stage of glaucoma. There, where we come to this system or this staging system, which is include what we mentioned or trying to overcome the defect we're faced with the Amral's methodology. Here, what the stages rely on, they divide to 10 stages from 1 to 10, and they start with what they care about or what the system is staging is the nearest or the narrowest rim width in regard of the other rims. So if we have, let's say from stage 4, if you have a rim which is less than 0.1, you will stage this patient as a 5 rather than caring about the other aspect of the rim. So if the patient reach to 0 or there is no rim, we start to have what we call stage 6. After that, you document the extent of the 0 or no rim area. If it is within a degree, you will have each stage with certain degrees. And this gives us more about the extent or the advanced, especially in early or in the middle area of staging system with a patient with a glaucoma. Other systems have been done also to stage a glaucoma or to stage an optic disc patient is this system stage, which I want to here to elaborate or give a hint for assisting the patient. That what they did, they divide the patient to, or they divide the changes to 3 stages or 3 divisions. First, in early beginning of the glaucoma, where you can see here the disc changes is more clear than the visual field changes, which is minimum and come later, which is explained by the changes of the disc after time. After that, you have minimum change in the disc, while you have a huge different you have a huge difference in the field staging system or and the field changes. While in the end, you only have a minimum in both field and disc. What is the importance of that? That's if you label your patient in early stage on, you have to rely more on your disc appearance and disc changes, and don't wait to have visual field changes to know that the patient is progressing. While if you have a patient with large cup to disc ratio, moderate to severe cup to disc ratio, you don't rely on the disc appearance, rather than you rely more on the visual field changes, which give you a hint that this patient is progression or not. At the end, both will be equal, and you will have a difficulty to confirm that the patient is progressing or not. Diagnostic test, we always have to do bachymetry for our patient to make sure, as we mentioned earlier on, that the patient with thin cornea, they have a higher risk, and this one might change the IOP measurement. Also, visual field evaluation is a very important test that you have to order for your patient, and also imaging optic nerve head and retinal nerve fiber layer and other modality of imaging done. So management, how we should manage our patient with the primary open-angle glaucoma. First of all, you need to know that primary open-angle glaucoma is a stages, or it is a spectrum of disease, have a stages and have a different area or different progression. So know where is your patient, know what stage a patient your patient is, and try to treat that patient accordingly. So what is your goal from treating a patient with a primary open-angle glaucoma? As we mentioned, that the only risk factor that we are able to modify is IOP. We always try to control the IOP in the target range. We try to stabilize optic nerve status, also stabilize the visual field changes. As we see here, that with the same DDLS staging system, that if you have a patient changes or progression, you should know that there is a different type of progression. Some of the patients, they will have stability, or they will be stable for a long time, while some patients, they progress very fast and very quick, and some they're just a linear or slowly progressing patient. So in that area, you should know which one your patient is. Are you dealing with a patient that progressing very fast? You need to interfere faster, or your patient is stable. You don't need to go very aggressively with the patient, or the patient is getting deteriorating with the time, and you need to interfere with him. So knowing the progression rate, knowing how is your patient doing with your management is a very important. So you don't lose a very fast progressed patient, while you don't go aggressive with a patient where they have very low progression. So in every patient with a primary open-angle glaucoma, I think you should have a target what we mean by target IOP, that the IOP will have the range of IOP that the patient will not have any visual field or visual deterioration or progression. So that the IOP, whereas the patient will maintain his field and will maintain his optic disc cupping. It's different from patient to patient, so you need to individualize it to your patient and make sure that you revise it and you change it if needed with the time. It's not a fixed number, and it's not fixed for all patients with a certain cup to disc ratio that they will have lower IOP. Even a patient with a high cup to disc ratio, if they are tolerating a good IOP and there is no visual prognosis, you should keep in mind that every patient have his own target IOP. Also keep in mind that there were a factor that contribute to choosing a target pressure or target IOP. First of all is the staging of glaucoma. As we mentioned, the more advanced, the more target IOP, lower target IOP you want to go with. Also the age of patient. Make sure that you don't over treat or over burden the patient with the treatment. If you're not sure about if you don't set their IOP target. For example, if you have a patient with the age of 90 years old and his IUP is a borderline and he is stable and you're doing fine, you don't want to push and go for intervention that might patient not benefit from it and might not get the benefit from doing surgery, and you might change his life by doing this surgery. So make sure that patient age and life expectancy is targeted also to the patient. And always remember to change the target IUB if you feel that the patient is progressing or the patient is stabilized for a long period of time. Now we'll talk about treatment and option of treatment. As a primary open-angle glaucoma, we used to have the first line treatment. The only option as a first treatment is a medical management or medical treatment. For medical treatment, it is you should know that the IUB is lowered by three mechanisms or three ways. First one is increasing the outflow of aqueous humor. Second, decreases secretion of aqueous humor. And the third one, which is the more aggressive one, is to decrease intraocular volume by decreasing the vitreous body of vitreous cavity. As first-line treatment, it is proven that prostaglandin is the most frequent choice in first-line treatment for a patient with a primary open-angle glaucoma. And mostly the advantage of prostaglandin is that it has the highest percentage of decreasing the IUB, and also it is more convenient to the patient because it's used once daily, and more patient will comply with it. Other second line or second line of treatment also include beta blocker. One note about the beta blocker, you should keep in mind that nighttime dose of beta blocker might give you a visual field progression. And this is explained especially with a patient who have low blood pressure that have a nocturnal reduction of systemic blood pressure and low perfusion to the optic disc and progress the optic disc damage. Medication is a lot and huge in the market. As we mentioned that primary chosen prostaglandin medication have the highest IUB reduction rate all over the medication. And also remember that alpha adrenergic agonist is an FDA approved for a patient or safety categorized as a class B for a patient with a pregnancy. Other medication also used, and they have whole systemic and side effect that you should keep in mind when you prescribe this for your patient, and make sure that the patient does not have a contraindication for that medication. So now we'll go to other option nowadays is available for a patient to start with. It is a laser trabeculoplasty. Especially selective laser trabeculoplasty is used to be the first line of treatment for a patient with a primary open-angle glaucoma. As you can see, there is multiple randomized clinical trials for that, and all of that proving that the safety and efficacy of laser trabeculoplasty for a patient with a primary open-angle glaucoma. I will highlight or talk only in the newest randomized clinical trial that have been published in last couple of years, is the LIGHT study. What they did, they initiate either medication for one arm and SLT for the other arm for a patient with a primary open-angle glaucoma and even ocular hypertension patient. They have around 718 patient or a number of patients and they followed them up for 3 years period of time. What is interesting that they found that SLT and medication, it is equally result in IUB reduction for a patient with the primary open-angle glaucoma and ocular hypertension. And also what's more interestingly, that they found that SLT is more cost effective for the patient than medication use for that period of time. So it is not only evidence that it's safe and effectiveness, also it's cost effectively that you start your patient with SLT, or at least you give him the option to start with SLT. And as we all know that SLT is a selective laser absorbed by pigment cells, which is less damage or less destructive than argon, which was used, the argon laser trabeculoplasty, and you can repeat it over time. What about surgery? What options of surgery we have? Here in a primary open-angle glaucoma, we have the additional type of surgeries that we can do, which is non-penetrating. Also, we have what can be done for all type of glaucoma, which is a trabeculectomy and tube shunt surgery. For non-penetrating, we have the deep sclerectomy and the viscocanalostomy and canaloplasty also. As a trabeculectomy, also it has been studied that with the collaboration initial glaucoma treatment study, that they initiate trabeculectomy versus medication as a first line. What they found that the patient have a slower or a slowed visual progression, visual field progression among the patient with advanced visual field loss. And also another study which they did in Moorfield, the primary therapy trial, they start the patient with trabeculectomy. And also they found that there is no visual field progression or deterioration. And this is a very important notice that if you have an advanced patient, advanced glaucoma, it's wise sometimes to start with a surgery for that patient to preserve what field he has, rather than starting a medication and slowly the patient losing his field and you lose the remnant of his visual field, especially if they are advanced glaucoma loss. TVT is a study that they studied tube versus trabeculectomy. In the beginning, they start with a patient who had surgery before, and they randomized them either to do trabeculectomy or to do tube surgery, non-valved per-valve glaucoma implant. And what they found that the tube shunt surgery had higher success rate than trabeculectomy during 5 years follow-up. But both have the similar IOP reduction. What the criticism was for that study is that the patient already had the surgery before or had the trabeculectomy before. That's why they bring another type of study, what they call primary tube versus trabeculectomy, where it's the patient randomized with no history of glaucoma surgeries before. What they found that after 3 years, the success rate were similar between two groups, and trabeculectomy groups demonstrate lower IOP with a fewer medication than tube group. So again, backing up the trabeculectomy, it's a safe and it is well-tolerated surgery for a patient with primary open-angle glaucoma patient. What about combined surgery? As we all know that cataract surgery per se, it is some sort type of glaucoma surgery, because after cataract, patients might experience a lowering of the IOP, which around 2 millimeter mercury on average. For combined surgery, we always think about combined surgery if the patient have any cataract changes and you're planning to do glaucoma change, you make sure that you do both, because doing cataract surgery after glaucoma surgery might compromise the glaucoma surgery you have already done. And the
recording in progress.
As I mentioned before, that it is an area of argument that patients with advanced glaucoma is that DS will give lower number of number of IUB or not, as was happened with the TRAP. So some they tend to do trabeculectomy to get more effective lowering IUB than doing a DS. What's done this study, they compare between primary open-angle glaucoma patient. They did with a bilateral disease. They did one eye with the DS and the other eye with trabeculectomy. And what they found that the patient with DS in the early post-op first day and first week, they were having a lower IUB actually, and which is have a significant p-value. But at the end of 12 months, they were similar in both group, and they have similar IUB reduction. As we see here also in this paragraph, that both groups in the beginning, they have a lower IUB, then at the end of 1 month, they are almost similar without significant p-value difference between two groups. Regarding complication, this is the area why we choose DS and why we prefer to do DS for the patient rather than TRAP, because have a lower risk of complication. So it is proven that the patient with the DS having a lower complication rate than a trabeculectomy patient. And they found that the complete success rate is around 79 in deep sclerectomy patient and 85 for a trabeculectomy patient, with a qualified success 92 and 94 for DS and trabeculectomy, which is almost similar between two groups. Now we'll go through mix very quickly. This is the future of glaucoma specialty, and this is where the area of new devices and new approach or new procedures done through recent development of the glaucoma. So what is MIGS? What is minimum invasive glaucoma surgeries? It is a way to approach glaucoma patient ab interno rather than involving the conjunctiva and opening the conjunctiva and have a higher risk of complication and compromising the conjunctiva. To our knowledge, still this is a new devices and new approach that we're testing. Still, there is no strong evidence about that. And at the end, always those type of glaucoma surgeries fit for a patient mild to moderate glaucoma changes, and targeting IUB is an upper or higher teens, where if you're looking for a lower IUB reduction, still the trabeculectomy or old procedures is the gold standard procedure for those patients. I divide a mix, or it's being divided to 3 groups, depend on the area of works or area you're working on. Either you are working in trabecular meshwork or Schlimm's canal, or you're creating an opening to the subconjunctival area, or there is a connection to the suprachoroidal area, which is done by CBAS microstent, which is withdrawn from the market. For subconjunctival area, Zengel stent is a very promising implant that giving you some sort of flow from anterior chamber to subconjunctival area. For approaching trabecular meshwork, you have to either stent or cut or dilate. For dilating, it is the same as what we did with the canaloplasty ab interno, but it is from anterior. Ab interno canaloplasty, EPIC, it is when you open the trabecular meshwork and you pass the track or the guidance in the trabecular meshwork and you dilate that trabecular Schlimm's canal. Cutting, you have different way to cut or to tear the trabecular meshwork, either by blade or by a suture or by the track or assistant track or by diathermy opening. Stent, as we all know, the famous type of stent, which is an eye stent implant, which you are implanting the stent to pass by the trabecular meshwork resistant and drain to the Schlimm's canal and creating like a canal or opening from anterior chamber to Schlimm's canal. For trabecular meshwork based mix, you should keep in mind that you're not overcoming or you're limited by the resistance of episcleral vein pressure. So keep in mind that if patients have high episcleral vein pressure, that they will not benefit from doing trabecular meshwork canal-based mix. Here we'll talk about subconjunctival mix, which is the ZIN, as we mentioned earlier, which is a promising procedure or promising stent because as you see here, it's FDA approved for refractory glaucoma. And as you will see later that the lowering IUP or lowering, yes, here, from summary for publication done for ZIN, as you see here, the lowering of IUP is significant and you can target lower teens IUP with this stent, which is make a huge difference. As we mentioned, makes usually give you a little or minimum lowering IUP effect, but in ZIN, they promise as they are working to get IUPs lower and lower. Finally, I just want to notify you that this also have been drawn with this is not also this is withdrawal from the market. The idea of the CPAS was to have a canal or to have a connection between anterior chamber and suprachoroidal space. And withdrawal happened because there is significant endothelial cell loss with this implant. So they withdrew it from the market. With this, we reached the end. Thank you very much. I'm sorry, we have 2 minutes to answer the question.